My name is Dr. Veronica Ajewale, a clinical pharmacist by training. I am also the director for the Community Engagement Core of Center for Biomedical Minority Health Research from Texas Southern University. We are very excited this morning to be here to present on childhood cancer, what the community should know. Next slide, please.
Texas Southern University's Center for Biomedical and Minority Health. Southern University's Center for Biomedical and Minority Health Research Community Engagement Core is funded by the National Institute of Minority Health and Health Disparity Research Center for Minority Institutions program. The CEC works directly with communities to identify and address health-related concerns and reduce health disparities related to ethnic minorities. We provide health education and partnerships with healthcare systems, federally qualified health centers, community and faith-based organizations. For more information, visit us on social media at CEC Texas Southern U or give us a call at 713-313-1233 or send us an email at cbmhrcommunity@tsu.edu.
Who we are, and we have the pleasure of having one of our principal investigators with us this morning. Dr. Liang is in the house. Please help me to appreciate Dr. Liang. Thank you for joining us today. Thank you very much. Once again, I welcome each and every one of you. We would have question and answers after the speaker session and after the panel discussion. So please feel free to write up your questions. And for those that are joining us online, post your questions in the Q&A box. Next slide, please. And we want to say a big thank you to our hybrid location. We are in a really beautiful space this morning here at Fallbrook Church. Fallbrook Church is located in North Houston, and it is led by the founding and senior pastor, Pastor Pender. The community is reached one home at a time while changing how people perceive the church forever. The first public service took place at Gray Elementary School in September of 1994, and the congregation went on to worship and fellowship in individual homes and office space, and a co-leased church until closing on a 6.14-acre land on Walter Road. The first building, the auxiliary building, was opened in late 2001, which was then followed by the second building in August 2004. On Easter Sunday of 2009, the third building, which is the worship center, which is where we are right now this morning, is a 2,500-seating worship center, double gym, bookstore, cafe, and space for meetings, training, conference, classes, camps, sporting events, and so much more. In need of even more space for classrooms and activities, a fourth building, the Children and Youth Building, was opened in December of 2013. This three-story, 82,000 square foot facility offers 30 classrooms, 24 offices, a gym, full-service kitchen, concession area, indoor play area, and 3 custom-made aquariums. Fallbrook Church currently houses a K-12 charter school, a before and after school program, a day and a daycare. It serves over 10,000 members, and more than 3,500 individuals have accepted Jesus as their Lord and Savior and have been baptized in this church. So thank you again to the leadership of the church and also to Ms. Shalise Archett. Thank you very much, Ms. Shalise, for bringing us in, welcoming us, to the IT team, the facility team, everybody that has, been incredibly helpful in bringing us, to be able to have this event at this location this morning. We are really grateful to you guys. Next slide, please. We also want to say a big thank you to our sponsors. Even though we are originally grant funded by NIH, there are certain, things that we need support with, like getting gift cards for attendees, food, water, and all the other things that we do. And we want to say a big thank you to AFLAC, Walmart, and Aetna, who have, provided donation and sponsorship for the events that we have. And also, I want to say a big thank you to all our team members. This morning we have Virgil, who is our program manager. We have Sneha, and some of the volunteers are out there, supporting today's event, and I do appreciate each and every one of them. Next slide, please. Again, I want to say welcome to everybody. This is our December seminar. You can please scan the QR code. On that QR code, you would have information to complete the survey. Like we said, we have grant funded, so survey completion is very important to us so that we can receive feedback on what we need to do differently. For those that are joining us online, we will be posting the survey links, online for you to be able to join us and, share your feedback with us. If there are anyone either on site or online that is a community health worker, you need to please complete the sign-in sheet so that way we can issue your credit to you. And for those that are on site, we will be giving $15 gift card for our eligible attendees. So the only way to be eligible is for you to be on site, complete the survey, and also follow us on our social media links. If you do those three things, then you will be eligible to receive a gift card. Information about that will be at the booth in the lobby at the end of the session. Next slide, please. Now it is my ultimate pleasure to bring up stage my very dear friend, an amazing colleague, a remarkable pediatrician who focuses on hematology and oncology, in person of Dr. Rain Rouse. Dr. Rain Rouse is an associate professor and associate director of community engagement from the Office of Diversity at Baylor College of Medicine. She serves as a physician on the bone marrow transplant cell transplant program at Texas Children's Cancer Center. Dr. Rouse is board certified in pediatrics and pediatric hematology oncology by the American Board of Pediatrics, spending a clinical time seeing leukemia and lymphoma patients. Dr. Rouse is an avid volunteer serving for several years for the Periwinkle Foundation events and programs for children with cancer and other life-threatening diseases. Her fluency in Spanish has allowed her to provide care to children around Texas, as well as in small villages in Bolivia. So please, without further ado, join me in welcoming upstage Dr. Rain Rouse. Thank you.
Good morning. Thank you. Good morning. Thank you. Hi, everyone. I'm so excited to be here with you all. And we're going to talk about childhood cancer today. And how many in here have ever known anyone with childhood cancer? A few people. Okay. All right. So we're going to learn about the truth about childhood and adolescent cancer. We're going to learn to distinguish between some of the facts that are actually true and some of the fiction things that you may read on the internet or hear people say. And we're going to talk about some of the causes and risk factors for childhood cancer, which are actually very different than for adult cancers. We're going to talk about how to screen and protect against preventable cancers that can develop during childhood and adolescence, though they may not show up until later on. And I actually have some really great goodies that talk about exactly how you need to screen and prevent. And then importantly, we're going to talk about how far we've actually come with diagnosing, treating, and curing childhood cancer and what the community can do to help. The reason this is so important is because there are actually more people in this room who know someone who's had a childhood cancer. It's not a coincidence because many of you are people who work in a hospital setting, who have community sort of ambassador fellowship health ministries, who are in the healthcare field, who may be in pharmacy school, who may be at Texas Southern and used to doing these sorts of events. But most people that I talk to, when I talk to a room full of people, have never met anyone with childhood cancer. Some people don't even know that kids can get cancer. So my goal today is to help you all, not only as healthcare workers or community health workers or church members, as college students. I want to help you all understand what our role is as anyone who is not dealing with childhood cancer and how you can actually be an ambassador for childhood cancer and cancer research. It truly takes the entire community to cure a child with cancer. And when I say that, I'm 100% true. Anyone out there who has kids? How many of y'all have kids? So we all know, Deborah raised her hand that she has kids. I guess the little brother, Jeremiah. But so we all know that raising a child is a lot. There's a lot that you have to deal with. So imagine your child being 3 or 4 or 5 years old, or even a teenager, going through all the things that teens and preteens go through and getting a diagnosis of cancer. That's not something that only affects that child. It affects the parents, it affects the aunts and uncles, it affects the grandparents, it affects the kids in the classroom, it affects the people at daycare, it affects everyone. And so it really is it takes a village and a ministry, like we say when we talk about worshiping. And we're going to talk about what being a community cancer ambassador means. So I'm going to start with some true or false. Let's see how savvy y'all are, okay? So true or false, I'm going to call y'all out. You're going to have to raise your hand. If you're online, you can do your raise your hand feature. So true or false, most childhood cancer is passed down from a parent, meaning it's hereditary or genetic. Okay, we got some of our kids in the audience say false. Who thinks true? Anyone think true? Anyone? We have a couple truths. Okay, we're going to come back to it, but I'll reveal the answer and I'll tell you about why that's true or false. So it's actually false. So unlike a number of adult cancers, like breast cancer, for example, where you may have a strong family history, colon cancer, where you may have a strong family history. Oh, okay. And for our online folks, you haven't missed anything. You just missed the first true or false. Can you advance the slide, please, to the first true or false? We'll go right through that and advance to true or false. Okay, perfect. And you can click one more time and you'll see that the answer is false. And I'll tell y'all exactly why that is false in a few minutes. All right, next slide, please. True or false, some cancers that develop in childhood or adolescence are preventable. What do y'all think? Yeah, I see some truths. Anybody think false? False? We got some falses. Okay, we'll come back to that. Let's see what the answer is. Next slide. True. The answer is true because it says some cancers that develop in childhood or adolescence are preventable. All right, next slide, and we'll come back to that. True or false, there are vaccines to prevent certain cancers. Is that true? Are there vaccines that can actually prevent a cancer? This is a hard one. This is a $100 question, $200 question. I see some falses out there. Anybody think that's a true? Oh, we got a lot of truths. Okay, let's reveal it. Advance. True, there are some vaccines, and we have some information about some of them today, and I'll talk about it in a little bit. And next slide. Some cancers are more difficult to treat or have worse outcomes in some races or ethnicities. We know this can be true for adult cancers. Is this true with childhood cancer? I see some truths. Some people say no. Okay, let's advance. Let's see what it is. This is absolutely true. All right, next slide. True or false? A clinical trial or research study is never appropriate for a serious illness like cancer. What do y'all think? False. That makes me so happy that I hear y'all yelling out false. Let's advance. Let's see what it is. It is absolutely false, and I'll tell you about why. All right, next slide. True or false? Most cancer clinical trials involve experimenting on a patient as if they're a guinea pig. What do y'all think? And you can say what you really feel, and I'll tell you the truth about that. It is absolutely false. Advance. All right, next slide. Okay, so let's talk a little bit about childhood cancer, because some of you have known someone who's had childhood cancer, but the cancers that kids get are actually quite a bit different than the cancers that adults get. So this is a wheel that tells you the breakdown, and by far the most common childhood cancer is leukemia, okay? So 9 out of 10 times if a child has cancer, it's gonna be leukemia, which is a blood cancer. Adults can get blood cancers too, but the types of leukemias that kids get are a little bit different. We also see patients that have lymphoma, so that's the second most common type. And then the third most common type, which is actually tied with lymphoma, are brain tumors, brain cancers, okay? So those are the big three. But then after that, you have a number of other types of cancers that hardly ever occur in adults. So we see patients who have these different soft tissue sarcomas. We see something called neuroblastoma, which is extremely rare in anyone over the age of about 20 years old. We see a number of different bone tumors, and we see some kidney and liver tumors, but they're different than the types of kidney and liver tumors that we see in adults. So often, when people talk about childhood cancer, to me it seems very common. To Michelle Fritsch, who works with me, it seems very common. It's actually quite rare. But when you look at the breakdown, I'm going to tell you how many people, if you had to look at a whole cohort of people, would actually have cancer. And this is why it's not uncommon for those of you online, if you've never met anyone who has known anyone who's had childhood cancer. Next slide. So one thing that is really, really important to know, and what we want to know about any sort of disease or cancer, is what is the survival rate? Okay, and when we think about survival rate for a child, if you are diagnosed at 2 or 3 years old, when we look at overall survival, we want that survival to be 20 years, 30 years, 50 years, 70 years, 80 years down the line. Usually when we look at survival, though, in cancer, we calculate it based on a 5-year survival rate. And so overall, that top bar, we do really well with childhood cancer. We cure about 88% of children with cancer. There is not a single adult cancer where you can say that you cure 88% of all comers. Okay, when you look at the breakdown, you'll see that we do better in some cancers and we do a little bit worse in some cancers, but most of them have over a 50% cure rate. This is really, really, really important to know, and I'm going to tell you how we've been able to get to these amazing cure rates. Next slide. So when you think about a child, and a child who's diagnosed or 2 or 3 years old, and you think about the time and years lost if we are not able to cure a child, or if they have long-term issues from their cancer, and the average life expectancy in the US, and this fluctuates, was about 78 in 2016. It's a little bit higher right now, but the average age of death for a child with cancer is around 11 years old, okay? So is it ever acceptable for an 11-year-old to die? Absolutely not. So everything that we do in childhood cancer is to try to identify these cancers early, because many of them are not preventable. Many of them are not things that you can screen for the same way that you screen for an adult with cancer. Many of these are caused by a number of different things, and the child is usually the first person in their family to ever have a cancer. And so this is why routine visits at the pediatrician are so important, or your family medicine doctor. This is why if you ever bring your child somewhere and something is not quite right, and we talk about this with adults too, and you see the doctor and they say, oh, maybe it's this, we'll come back in a week, and you come back in a week and you see a different doctor and they say, well, it could be this. And you're saying to yourself, you know, all of these tests are, you know, I really want them to do some blood work on my child, or I really want them to be evaluated a bit more. This is persistent. This isn't like my child. And with children, if it's a 2-year-old, it may just be them sleeping a bit more, right? It may be them saying, I don't want to eat. It may be them hitting their head. It may be you seeing a weird rash on them. It may be something like that that's not very specific. So the important thing for all of you, whether you're an adult, whether it's an elderly person you're caring for, or whether it's a child, you know your child, okay? So when something is not right with your child, even if childhood cancer is rare, even if some of the other diseases we deal with are rare, it's your job to advocate to make sure that you're saying, I know that you said, let's wait another week, doc, but they're not back to baseline. So I really am concerned. And they really are limping around and saying that they don't want to get up, and that's really not like them. And I know you said that maybe it's growing pains because that's the most common, but at this point, I'm getting more concerned about it. So having that knowledge and being able to think about those things. Next slide. So the good news is we are creating long-term survivors every single day. So literally today, now it's about over 500,000 childhood cancer survivors in the US. There are people that we work with every day. There are people around you who you may not know that they had childhood cancer and are doing very well. And there's one reason that we have been able to get there. Next slide. And that is because we've become very sophisticated in the way we treat cancer. So anytime anyone thinks about cancer, you automatically think about chemotherapy, right? You think about, even if you've never seen someone get chemotherapy, even if you don't know the name of a chemotherapy, you know that we have to use special treatments that are designed to target and kill cancer cells. And so the standard way that we treat pediatric cancer is really very similar to the way that we treat adult cancers, is that we use a combination of chemotherapy, so meaning any medicine or drug that is supposed to kill cancer. We often use radiation depending on the type of cancer, and radiation can help stop cancer cells from growing. And we use surgery in some cancers, especially ones that occur in organs like in the liver or in the kidney or even in the brain. Next slide. But the thing that has been most impactful in improving outcomes for childhood and adolescent cancer is research, period. When I started my fellowship at Texas Children's in 2011, so I was already a pediatrician, but I was learning how to be a cancer doctor and blood disease doctor. I remember very specifically rounding, which is what we do in the hospital when we go to see patients, and diagnosing new patients with cancer and having these discussions with them. I was in training with the attending physician that I was on with, and being able to tell them, we cure forever over 90% of kids with this type of cancer. And I remember very distinctly coming outside of the room and the attending that I was with, who'd been doing this for a long time, who said, 30 years ago, it was 20%. And that was crazy to me. And her saying, when I was a fellow, we didn't have any of these medicines, we didn't have any of these treatments, and my rounds were very different. Where every room I was going to, I was having a very different conversation. And so I understood research, I believed in research, but I had not yet seen the marvels of research, the true kind of modern scientific miracles of research, until I was able to see in these individual patients how far we had come. Next slide. So what clinical research has taught us is better ways of screening and preventing some cancers. There are a few cancers that can develop in childhood that you actually can screen for. One of them is cervical cancer, like HPV. That's a virus that causes that, and there's a vaccine available for that, and we recommend doing it during childhood. Those of us who are older didn't have the opportunity to get those vaccines when we were younger because they weren't out yet. But this is a very preventable cancer, and it doesn't just cause cervical cancer. It can cause penile cancers, it can cause anal cancers, it can cause head and neck and throat cancers. And so this is a cancer that hopefully in 15, 20 years, we will hardly see anymore, because we'll have this whole cohort of kids who've been vaccinated against it. We're able to prevent and screen for skin cancers. A lot of patients have very fair skin. There's a common myth that African Americans and Blacks and people who have more melanated skin don't have to wear sunscreen. That is a myth. You actually absolutely can burn, and you absolutely can develop some types of skin cancers. We learn the most effective combinations of medicines to treat children with. Children are not just little adults. They are not. Their bodies work differently. Their bodies are actually a lot stronger than ours. Their cancers are often extremely aggressive, but because their organs work so well, because their bodies can take a lot more than an adult, we're able to use very sophisticated but complex regimens of chemotherapy medicines that can target their cancers in multiple different ways. And they're able to even sustain being treated with cancer for 2 years, for 3 years, getting very intensive cancer. This is part of the reason why we have been able to improve outcomes. And importantly, we've learned how children with different mutations or different features of their cancer respond differently. This is really important. We're able to actually, when we diagnose the cancer, we can do all kinds of fancy tests where we can tell you the exact fingerprint of that cancer. We may know you have neuroblastoma or you have lymphoma, but we can tell you this is the mutation associated with. It's not a mutation in your body, it's a mutation in the cancer. And we can tell you in our experience over the past 40 years, patients with this mutation did better with these medicines. This mutation, because it's so common in this type of cancer, we can say we have had scientists working for years to create a medicine that specifically targets this mutation. And in addition to the other chemo, we'll give you that. We've been able to say, you know, kids with this mutation, they tend to do a bit better. They're less likely to have their cancer come back. So we can actually peel back, scale back, and not do as intensive therapy. So this is really, really important. Next slide. They also have taught us whether outcomes or side effects differ in different populations. This is a question that I get asked a lot. And as an African-American pediatric oncologist, I often, especially when I interact with patients who are racial or ethnic minorities, they'll ask me, do these medicines work different in my child? How many Black kids have you treated with this? Do you think that their body will handle it differently? And my response is often, that because we are able to test these cancers so extensively, we are able to identify these genetic features that may be biological, that may be related to genetic ancestry, but not necessarily related to your race. So this is the information that we have, and because we know this, we're able to kind of tailor and personalize care. Importantly, because when I'm curing a kid with cancer, I'm curing them so they can grow up, have their family, have their job, do all the things, be grandparents. So I'm looking not only at 4 or 5 years from now, which often with adults, they have 3-year survival and they have overall survival, and they're not trying to calculate 20 years out, 30, 40 years out. So for us, we're trying to think about when my patient grows up, how can I make sure that they're not at extremely high risk for breast cancer because they've gotten radiation? How can I make sure that they're not at extremely high risk for heart failure because I've given them these heavy drugs that they can tolerate, but they're gonna live for another, 50, 60 years. And also how our therapies affect learning, how they affect quality of life, how they affect fertility. We work very closely with a multidisciplinary team. Michelle Fritsch, who is here, who will join me on the panel, is social worker extraordinaire and in our psychosocial division, and so much more than that, and really helps us remember in our day-to-day life as we're taking care of these patients, all of the other things that we need to address to take care of the kid, to take care of the entire family. Taking care of a 2-year-old is very different than taking care of an 18 or 19-year-old or taking care of a teenager. Taking care of a patient who's from a single parent home and they happen to live 3 hours away but had to come to Texas Children's because there's not another pediatric cancer center in their place. Giving people therapies that I say, you actually have to stay within 20 minutes of the center because I need you to be able to get to our emergency room immediately if there is a problem. That's very disruptive for the entire family, right? Making sure that kids aren't falling behind. Our kids typically don't fall behind because they're in school. They're in school, in the hospital, getting chemo in school. And we have school coordinators. We have an amazing system where they're still able to do lots of really normal things because we want them to continue to have a normal childhood despite having to go through all of this. And then importantly, how to help patients and families cope. And Michelle is going to talk about a lot of the resources that she has that are absolutely amazing. We often partner with organizations and then create resources of our own. Next. Okay, so the hard facts are, when you think about numbers, 42 children are diagnosed with cancer every day in the US. So that's a very small number when you think about the number of adults diagnosed with cancer, right? So this is why it's not that uncommon if you have never heard of anyone being diagnosed with cancer, and why some people are actually surprised. Most of the patients that I diagnose, when I talk to their families about the fact that their child has cancer, they say, I didn't even really know kids could get cancer. I didn't think, how could they have gotten cancer? It is the #1 cause of death by disease in children. Okay, so this is why it's so important and why we have to talk about it. But most standard childhood cancer treatments are decades old. decades old. Now, you can think of that two ways. One way to think of it is we have identified some really excellent ways of curing over 85%, 88% overall of kids, and these medicines work really well. But the other way to think about it is it's often quite archaic. And I'm a scientist too. I'm a physician scientist. So when I think about, we've been using this medicine for 40 years, and we know everything about it. We know all the side effects, good and bad. We know how to try to prevent them. But I also think about, shouldn't we be looking at some other medicines that have less side effects that you don't have to take for an entire 3 years? And so that is a lot of what we do as pediatric cancer doctors. All of us are researchers. Some of us work in the lab, some of us do clinical research, but we're constantly saying 88% is not good enough. 90% is not good enough. Some childhood cancers are 95%. I don't want 95%. I want 100% of kids 100% of the time. More than 15,000 children are diagnosed with cancer each year in the US, and nearly 60% of childhood cancer survivors do experience severe complications in adulthood. What does this mean? This means that while we have these medicines and combinations of medicines and treatments that are really, really good at putting a child into remission, this means that later on and forever, once they become a long-term survivor, every year, they have to go, and when they go for their checkup, it's a different kind of checkup. They have to check their heart, they have to check their lungs, because we know that there are long-term side effects that can occur because of our medicine. So we're trying to change that by moving research forward. And 2 out of 3 childhood cancer survivors will develop at least one chronic health condition due to toxic treatment. Next slide. So more hard facts to swallow are that advances in childhood cancer have been a real true success story in modern medicine. And death rates were about the same for Black, Hispanic, and white children in 2001, and they all went lower during the next decade. But in the past 10 years, these strides have really stalled, especially for Black and Hispanic patients. That is something. I've been an oncologist for 10 years. When I see that and I see this gap that's starting to widen, I, of course, say, wait a minute, that's not okay. Why is this? And I'm going to tell you exactly why this is. Next slide. The future of the way that we take care of cancer and a lot of diseases is really personalized, okay? So this is a good thing for everyone in the audience, everyone online. It is good that we're personalizing treatment so that the goal is that in 10 years, if you have to go in and get treated for cancer, that you will get a biopsy or get your cancer workup, and we'll be able to have all of this information and say you have this type of cancer, but it has this, and this feature. You know what? Instead of giving you all these different chemotherapy medicines, we've been able to find through clinical research and clinical trials that we can give you this medicine that you take by mouth. You can get only 3 months of these IV medicines, and then after that, you continue to take this medicine by mouth for the next year, and then you'll be cured. That is the goal. The goal is to personalize it based on your features of your actual cancer. Next. And so one of the most important things is the way that we're able to do this is look at mutations that are in your cancers. We're able to look at sequencing. We're able to do these fancy types of research like I do called immunotherapy, where I can take your actual cells, your immune system cells, and train them in the laboratory to target your cancer. But if we are not represented in research, and when I say we, I say me, I say African Americans, I say Hispanics, I say people that live in a rural area, people that don't necessarily believe in research. If your tumor, if there's not any of the same mutations in the research, basically the cohort of research specimens that we have, then we're not really able to identify the best way to treat you. Does that make sense? So this is really, really important, because the way that we're able to identify this many patients have this mutation is based on people saying, yes, when you do my biopsy, you're able to save a bit of it for research to study it. And historically, African Americans, Hispanics, Asians, Indians, Native Americans are not really represented in those research databases. So that's a big problem, because it means you're not represented when it's time to come up with targeted treatments. Next. So personalized cancer care treatments right now are often only available on a clinical trial. What this means is if you go to the doctor, whether you're an adult or a child, we will say, you know, this is the standard of care with how we have done the best with treating kids with this type of cancer or treating adults with this type of cancer. This is how we recommend treatment usually. With this treatment, 85% of people will go into remission and still be alive and doing well 3 years out. If you have this specific mutation, those odds go up to 90%. If you have this specific mutation, those odds are only 60%. You have this mutation where the odds are 60%. We have a clinical trial where we're testing our standard treatment, but we're adding on this specific medicine that in our research in the laboratory before humans and in animals, it shows that it may specifically target your cancer better. It may improve your outcomes. We don't know the answer yet. We don't believe it will be inferior, but we believe that it may give you benefit. A lot of the time, because of a number of reasons that many of you know that we'll kind of talk about, people are mistrustful of that and mistrustful of research. But if that's your only opportunity to have access to a study drug, if we knew that it worked better, we would give it to everyone, just to be clear. But when we don't know and when we're testing it, it's only available on research. Next slide. So the evidence is undeniable that African Americans are less likely to be treated with new personalized therapies. I am a physician scientist and I do groundbreaking immunotherapy research where people that 7 years ago I would be telling there was probably a less than 10% chance that I could put their cancer into remission. Now it may be over 80%. But when you look at these therapies, and you'll see them on TV and you'll see them in the newspaper, and you'll see these really amazing outcomes, the reality is, this is one for lung cancer, that 88% of people in the big study, which is over 821 people with kidney cancer, 88% were white, only 1% were Black, 9% were Asian. This is not because Black people and Asian people are less likely to have these cancers. So this is really a problem because you want to be represented in these trials so that we can actually push the needle forward with cures. Next. The other issue is that for a long time, data on enrollment of underrepresented populations, particularly African Americans and Hispanics, was not even reported. So we would see these outcomes and people would say, well, if it worked for all of these people of European ancestry, this must be the best treatment for someone who is African American or Hispanic or Asian and Native American. And while that may be the case, we don't want to be in a situation where we have to guess when we're talking about cancer treatment, right? Next. So despite us being underrepresented in clinical trials and data sets, Black people have higher rates of illness and death compared to white people. And this is across the board, okay? And I want to impress on y'all because a lot of time people believe, well, you know, have different rationales for why this is. What we know factually is if you are not represented in being able to be a part of cutting edge medical treatment and treatment that is less likely to cause a bunch of side effects, then it is going to contribute to lower likelihood of having a good outcome. Next. Next slide, please. Okay, so there are a number of barriers. You can click 4 times and it'll show all of them at the same time that patients report to being in clinical trials, and nod if you can feel some of this because these are the same things that all of us thinking about. A lot of people are really uncomfortable with if someone says it's a randomized trial, meaning there's like a 50-50 chance, right? They're like, wait a minute, so you've told me about this drug and why this drug might be better, and now you're telling me that after I agree that I'll go on the trial that it's only a 50-50 chance that I'll get it. A lot of people are uncomfortable with the concept of that. Sometimes studies are really strict. Trials will say, you know, normally if you're getting this treatment, you come once a week, but if you're on the clinical trial, you have to come 3 times a week because we have to check your blood and make sure you're doing okay, and that can be really challenging for people. And a lot of people have some fear, suspicion, mistrust, often due to historical things that have happened. One thing that's really important, and when we talk about that lower thing about physician-related issues that impact the patient, I always try to teach providers that overall, although we know there are a lot of barriers and people may have some misperceptions or mistrust, transparency and having access to the therapies is key. So when I'm talking to a patient, I'm very much keeping it real with their family also. Tell me what you're concerned about. Tell me about this. And that discussion isn't something that can usually happen in 20 or 30 minutes during your visit. It's something that takes a lot longer, and sometimes you'll need several visits. And I also say, who else do you want, who else would you like to be a part of this discussion? Should we call your family member? Because this is a family discussion. I talk about the historical things that have happened that have made us be mistrustful of research, but I also talk about all the safeguards that are in place because of those things to make sure those things never happen again. The burden is on us as physicians and as the healthcare system to make sure that when we're testing these new drugs that we want to be safe, but we don't want to overburden patients and families. So we have to look at ways that we can offset financial issues like travel, transportation, parking. If anyone's parked at a medical center, you know that that can be substantial, food, all of those different things. So I show these barriers to let you know that we recognize them, that we work in a number of ways to combat them. We have several members of Dan L. Duncan Comprehensive Cancer Center's Patient and Caregiver and Community Advisory Board here in the house today. And we're listening because it's important to make sure that we're addressing these things. Next slide. So I kind of talked about why lack of representation matters, but I'll just kind of beat it home one more time, is that there are some biological differences within cancers in different people that can be linked to genetic ancestry, okay? So there are, in childhood leukemia, Hispanic children are more likely to have a certain mutation of their leukemia and are more likely to have worse outcomes. We did not even know that like 8 years ago. We know it now because we have the ability to study those mutations that were not really studied before, okay? There are certain cancers that African American children tend to do worse. There are certain cancers that white children tend to do worse. And this is often linked to a biological difference within the cancer, but can be linked to genetics. And it's really important. One thing that is shown over and over in the research is that African American patients are more likely than whites to be diagnosed with advanced cancer. So y'all know, you've had people that you know, and it's not just African Americans who will say, tell you that they had a cancer diagnosis, and it's often a stage 3 or a stage 4. So this is really important to know that a lot of these cancers, if we can catch them earlier, we actually can treat them and they can be curable. And then one thing that we're working on in research is that often when we look at clinical trials, we have inclusion criteria, certain things that you have to meet. Some of these criteria historically have excluded certain populations. It'll say that you can't have high blood pressure, you can't have diabetes without a true scientific rationale for why that should matter on the study. We know that high blood pressure and diabetes are more common in certain populations, including African Americans. So this is something that we're trying to change. Next slide. Okay. And then so in databases, I'll just say quickly, we want to be represented. So if someone comes up to you, if you're going to the doctor and it's not just for cancer and it's for any illness, and they say, hey, we have to take this blood sample, would you mind if we take a little bit extra? It's not an amount that's going to be dangerous for you. It won't directly help you right now, but we would have the ability to save it for research. Often people's gut feeling tells them, no, I don't want that. I don't want my sample saved. I don't know what y'all are going to do. People think about Henrietta Lack's story, which there are so many safeguards in place now that in order to do that, you have to be told if your sample is ever going to be saved, ever going to be used, any of that stuff. You have to be told. But a lot of times people will think, well, if it's not, I don't think I want to do that. I'm not interested. But when we explain it to them that this may not help you right now, but it may help us understand why people that are between 30 and 40 are more likely to be diagnosed with this cancer, why people with this specific mutation, why people with high cholesterol, diabetes, whatever illness it is. So think twice about that. Ask questions about it if you have concerns, and try to be a bit more likely to sign on for that, because that's the only way that we can be represented in the database. I don't want to go to a doctor for a treatment that all of the testing and all of the knowledge they have on that disease is based on a European population that doesn't have the same genetic ancestry of me. I want to know that there's some other folks in that registry that are have similar genetic ancestry to me. Next slide. All right, so let's get back to our questions, and we're going to discuss a few things. Next slide. Okay, so it is very, very, very rare that a child diagnosed with cancer, that it was hereditary or genetic. It is extremely rare, okay? And so we always have to tell people this, because the types of cancers that kids get, again, the most common is leukemia, then there's lymphoma, then brain tumors, and some of the other solid tumors. This is usually not something that is genetic. There's not a genetic change in the child. There's the genetics of the tumor itself. And cancer in general is caused by mutations. You probably heard that before. This is why when you think about some breast cancers that are inherited, people may have that BRCA gene, right? And know that their mom had that or their aunt had that, and know they need to get screened earlier. People may have colorectal cancer in their family, and that is something that is not necessarily passed down, but it's something that they are at higher likelihood of. It's very uncommon for childhood cancer. There are some very rare syndromes where there are a number of different cancers in a family that are very specific, and we'll test the child for that, but it usually is not hereditary or genetic, and it's usually not something that they're born with. It's usually a culmination of mutations over time, and we know causative mutations, but we can't exactly pinpoint when it happens. Next. So that was false. Next. Okay, so mutations are the #1 cause of cancer in general. There are some links to certain exposures. If you all remember Chernobyl, in the Soviet Union, where if there are large radiation catastrophes, there were people that years later were developing cancers. So normally things like that, when there's some environmental exposure that happens, it's years later. You see those commercials. Have you or your family, were you at Camp Lejeune? Were you at these different places? And it's talking about things that may have happened in the past, those asbestos commercials about mesothelioma. Those are exposures that there are some links with with several adult cancers. It's very rare for childhood cancer. So people will often ask, oh my gosh, does my child have leukemia because of that x-ray I had when I broke my leg or when I had pneumonia? And usually not. There are some minor links to CT exposure, but it's usually a substantial amount. So we always tell the family this. It's usually not the same kind of cancers that were in the family. So usually what I'm telling parents is, this is not related to the cancer that your aunt had or the cancer that your grandfather had. There are no known foods or drinks or additives or anything that you consume in your body that you would eat that cause cancer in children, okay? I have to answer this a lot, because when we're, diagnosing kids, and all of you out there who said you're parents, or even if you're not, the #1 feeling initially is guilt. And how did this happen? Is this because of me? My child's only 1. It couldn't be anything that they did. It must be something that I did. And I'm always reassuring people that it is not because of something that they ate, even when they were pregnant, or some exposure or anything like that. It's usually not because of things that happened during pregnancy. Often what people will say, oh my goodness, I was sick during pregnancy. Was it this? And there are some more recent links to chemicals in the environment. So you often will see kind of these areas that are shipping or kind of pollution, or the train dumping type things. And it is not normal for humans in general. We are not supposed to be exposed to massive amounts of radiation and radon and chemicals just out in the environment. So those things, the reason that they can be linked to cancer is because they can cause mutations. And our body creates cells that are mutated every single day, and our immune system is smart enough to normally clear them out. But when those cells escape detection by our immune system, they can start to cause some mutations. And so that's something that when you go to the doctor, sometimes with certain cancer, they'll ask about exposures in the past. Next. Okay. So we already know that there are some cancers that can be preventable in childhood, adolescence, so you don't get them as an adult, but usually not childhood cancers themselves. So we talked about the HPV vaccine, we talked about actually a sunscreen for skin cancer. There are some liver cancers that are linked to heavy alcohol use. There are some cancers that when you're an adult, we know that your risk factors can be higher if you're obese with certain diet things. So it normally is not affecting the childhood cancer, but we try to teach kids, adolescents, and families about it early on so that they can practice those healthy lifestyle things early on. Next. All right, and so we talked about those. Next. Okay, there are vaccines to prevent certain cancer. There are. So vaccines, you know, they teach your body how to recognize something. So the HPV vaccine puts in a little bit of antigen. It teaches your immune system to say, oh, if I see that again, I'm going after that, not on my watch. That can't be in my body. And so the same way that vaccines do that for other illnesses, these are really exciting. And so there's also a hepatitis vaccine can help with certain liver cancers. So a lot of the research we do is we've been trying to create vaccines for cancer for a long time, and we've still do that, but in a different way. So some of the research I do is kind of like vaccination, where it's kind of exposing your immune system to a little bit of something and then teaching it how to be trained to go after it. Next slide. Some cancers are more difficult to treat or have worse outcomes in some races or ethnicities. Remember, this is actually true. We know this is true in adults. It actually is true in childhood cancer. And newsflash, we didn't even know this till like 10 years ago, 8 years ago. And you know why? Because we weren't looking for it. And when I say we, I say the global we, all of us, right? So we didn't have race and ethnicity data. We didn't have some of the sophisticated methods to look at these mutations, so we couldn't map them back to people. And so this is really important, and this is why representation is key, because I think about a patient who has a certain mutation, who is of a certain race and ethnicity a little bit differently, because I realistically say, I have evidence now that outcomes may be worse if we don't intensify treatment. So I want you to have the same exact odds of being cured forever as this other patient. And so I'm going to make sure that I treat you in that manner. Next slide. A clinical research study is never appropriate for a serious illness like cancer. Thankfully, all of y'all were like, false. But you would be surprised, or maybe not. People often believe that a research trial or something that is unproven is not appropriate for a serious illness. And you can understand why, because you think, no, I need to try it and true. But it's important to be open-minded and hear, what is this clinical research study? And tell me why you think it may be beneficial. If the provider you're talking to is not able to tell you exactly why it may be beneficial to you, then it's not something that you should participate in. There is always a reason why we're doing any study. If cure rates are 80%, in the write-up for that study, with our statistical methods, with all the scientists putting our heads together, we're saying, you know what, we think that if we add this medicine, we can get cure rates to 85% or 90%. We think that in this specific patient population, it will increase their outcomes. So listen to the rationale before you make a decision, because you want to understand, why would this be better for me than standard of care? That is something that's really, really important. Next slide. And we know that this is false, that you are not being experimented on. So bad things have happened in the past, especially with marginalized communities in research. Those things can never happen again because they happened before. The global, we learn from them. There are so many safeguards in place. There are entire bodies of people who their only job is to make sure research is safe. I serve on our institutional review board and data safety and monitoring board, where we review every single clinical research protocol or any type of protocol, even if it's not interventional, even if it's just a survey of you, to make sure that the subject, the patient, is protected and cared for, and then review the results as you go on. So this is one thing that's really important. And for you all, because y'all are basically community cancer research ambassadors officially as of today, where you go out and when someone says that, you say, you know, actually, do you know how many steps they have to go through? Do you know that everyone is aware? Like there are regulations and laws in place because of things that happened in the past. It does not minimize them, but we learn from them. So that's something that when I talk to families, I say, look, I get it. It's nerve-wracking. There are a lot of bad things that happened in the past, but let me tell you about all the things that are in place specifically to ensure that never happens to anyone again. So these are just be knowledgeable about it. Next slide. Okay, I think this is my last one. So it truly is our job to ensure that the road to potentially curative therapies is never closed. And so we have to understand that for childhood cancers and for all cancers. And you often may be a person that if someone you know, someone in your family, someone at school is diagnosed with something, they may reach out to you because many of you are in the healthcare field and say, what do you think I should do? They talked about this treatment option, I'm not sure. You can offer to be that person, to be there with them, to be on Zoom with them, to be on the phone with them. I do it all the time. And it doesn't have to be with cancer. I'm everybody's auntie, cousin. They're like, really? Y'all are related? I'm like, yes, we are related. Even though we don't look like it, we are related. Because you often need someone to just be able to hear that information with you, may not know anything about the disease or that treatment, but have that basic knowledge that research is the reason that we have been able to improve outcomes in just about every disease. And it is important to be represented, especially if you feel like, you know, maybe, I don't know, they don't have enough information on me. Sadly, sometimes I have to say I actually have not treated an African-American patient on this study. There's no reason for me to believe that outcomes would be different. There's no reason for me to believe the safety profile would be different because of this, and this, but I have to break that down and explain it because it is something that people think about. Next. I think that was my last one. Okay, so I lead community outreach and engagement for our Comprehensive Cancer Center. We do have some surveys for the savvy. You can put it, the technologically savvy, you can do the barcode. We have some paper ones if you want to do old school, no judgment, and just fill it out. And it talks about the things that you as community members, as church members, want to actually hear about education and cancer, similar to how the Community Engagement Corps does. It's not a survey feedback for this session. It's more a global kind of, what are you interested in hearing about? A lot of people want to hear about environmental exposures. A lot of people want to hear about herbal medications, which you talked about, and how, or you know, Eastern medicines and how those can actually be integrated into care. And so we like to be able to bring evidence-based medicine to you and talk about it in forums like this. And I think that may be my last slide. I think I have my email on there, but we can share that in other ways. So thank you so much for your attention.
Thank you very much, Dr. Rouse. We are really grateful. Thank you so much for sharing your expertise with us. I wonder if we have any questions online from Zoom. Do we have any questions? Okay, can you check with that person to type in if they have a question? Thank you. And then in the audience, do we have any question from the in-person audience before we move over? Yes, Dr. Liang has a question.
Dr. Liang, yes.
Thank you. This is going to be difficult, okay?
This is going to be a hard one. Let me get my wheels turning. From my buddy, Dr. Liang, yes. Oh, I don't think it's on. Hold on a second.
Nice talking. Thanks, Dr. Ross. My question is that what is the benefit of early diagnosis for those cancer, you know, in the kids?
This is such a good question. I'm glad you asked it. Okay, so you know how when we think about adult cancers, breast cancers, lung cancers, colon cancers, we know skin cancers, early diagnosis is key, okay? One thing that is still true for kids is that early diagnosis is key. However, because leukemias and lymphomas are different than some of these more solid tumors, it's not unusual for, you know, leukemia is in the blood, so it's everywhere, right? So parents are often like, did I come too late because their child is having a lot of symptoms? And I say, absolutely not. The reason why is that, number one, kids go to the doctor more often than adults. All of y'all adults know that. Kids, even medical professionals, kids who are like, suck it up, we're not going until you really are sick. But kids make it to healthcare. Even if they don't have a primary care provider, they make it to the ER. A teacher at school notices, someone notices something is off. So often what happens is that kids will come in and they'll have these nagging symptoms of leukemia, which are like leg pain, which there are 1,000 other causes more common than that, okay? Or they'll have, like, they were more tired. Well, it was a teenager. They were up till 3 o'clock in the morning. Of course you're tired. Or their stomach hurt, their head hurt, some non-specific stuff. What usually brings them to medical attention is that they develop signs that leukemia is expanding in their bone marrow. So they can have a rash over their whole body because their platelets, the cells that clot blood, are really, really low. They can be extremely pale and very fatigued and not wanting to wake up at all. They can come in and start having fevers for several days. So when we see them, to their parents and loved ones and to trainees, they're like, oh my gosh, is it too late? And the answer is absolutely not. It's that you present when you come to medical attention when it was time. Even kids that have a big tumor in their belly, the belly has a lot of room, especially in a toddler. They have those little pudgy, protuberant bellies that stick out, right? So one day, all of a sudden, a grandparent will be bathing a child and be like, this feels weird. This belly feels hard, and bring them in and they're like, oh my gosh, that means it's been there for a long time. So the answer is that we don't do staging the same. We don't normally have this stage 1, 2, 3, 4, because the cancers that we have, the most common ones are usually throughout the body. And fortunately, even when kids come and have had symptoms of a lymphoma, for lymphoma, they tend to come a little bit later because it's a teenager, they had a lump, especially if it was somewhere where a parent can't see, they kind of ignored it, and that's the usual thing, right? So because of that, the good news is that we still are able to really effectively treat them. And I really have to say this because childhood cancer is rare. So when you do have leg pain, headache, these different things, there usually is another explanation. So even when you take your child to the pediatrician or family medicine doctor or urgent care, that explanation they're giving you is usually correct, right? But what happens is things are just not right. There gets to a point where it's this series of things and the parent, teacher, someone is like, that's not right. That's the time that they need to come in for real diagnosis with me. And I tell everyone that you came in at exactly the time that you were supposed to.
So I have one more question.
Yes.
In terms of the drug treatment.
Yes.
I believe it's still the gap in terms of the discovering the treatment for the kids.
Yes, absolutely.
So the question is that from the clinical perspective, do you see a better risk? Because I think it's let's say same drug for anti-cancer drug.
Yeah.
Do you see a better response in terms of kids?
We do.
Oh,
so,
really?
So first things first, there is a huge gap in research funding for kids versus adults, period. Like millions more for adult cancer research versus kids. So we're trying to close that gap and advocate. And one of the biggest ways we can do that is childhood cancer awareness and people actually knowing kids actually get cancer. The second thing about the drugs, so most of the drugs that we use are drugs that were first tested in adults. We are able to give them at a frequency and at a dose. We're able to dose per body weight and per height and at a frequency that adults could never tolerate. So part of the reason that kids do so much better is that they can literally tolerate extremely aggressive treatments that we would. Now, Dr. Ajawola is a pharmacist. Like the doses that we use for our kids, she would be like, what? Especially because
kids are resilient.
I mean, we can give them once a week, and kids also haven't smoked a pack per day for 10 years. They usually aren't, binging on, recreational things and alcohol. And so their organs in general are typically more healthy and allow us to really push the needle, which is key. And they are so much more resilient than adults. I remind my parents all the time that because they're still running around and doing their thing, you forget that they're on chemotherapy. I'm like, so if they get sick, they're like, this just came out. I'm like, this child is on, we would be laid up in the hospital, unable to move for weeks. And they're like riding a motorcycle down the hallway of the hospital. So it's aggressive therapy that allows us to be able to cure them. But we're still trying to push the needle with research, because those aggressive therapies are the same ones that cause effects that can happen later on. So we're trying to peel back and be more mutation targeted. Excellent question.
Great question. Thank you. Okay, yes, sir.
Yes. Dr. Rouse, first of all, you're just awesome.
Aw,
and we just thank God for you. I'm Harold Hatchett, and I'm the bag carrier for Charlize. Dr. Rouse, I'm happy to see that the success rate for the cure is very high in kids. When a kid is diagnosed with cancer, it's a very traumatic event, okay? So my question to you is, when the diagnosis is given, is there an opportunity for, because it's psychological also.
Yes.
In your care plan, is there a psychological element in that plan to help the kid and the parents deal with this traumatic event?
100%. So the treatment and the diagnosis and the care of kids with cancer is so different than with adults. And I always say, if I get diagnosed with cancer, I'm gonna be trying to be treated at the Children's Hospital. I'm gonna be 62 years old, asking for the child life specialist. But it's a whole family thing, right? You're dealing with a child who may be at an age where they can't even begin to process, but they know they're in the hospital getting poked and not out with their friends and having to do certain things. And you're dealing with siblings who may not be able to come up to the hospital, but know that their mom isn't home and their dad isn't home and their grandma isn't home, and they know that their baby brother is sick. And you're dealing with the school, you're dealing with the church, you're dealing with the loved ones, you're dealing with all the aunties. So there's a lot of stuff that comes with that child. We take the care of the mental health, the social health, just as seriously as we do the physical health. And I'm gonna have Michelle Fritsch address this, because we literally work hand in hand from the very beginning to make sure that we are taking care of the entire family. And we have dedicated child psychologists that are dedicated to our patients with cancer. We have dedicated social workers, we have dedicated financial counselors, we have dedicated school folks that help get them in school. We have a whole psychosocial division. So I'll pass it to you, Michelle.
Okay, well, thank you, Dr. Rouse. So when a child's first diagnosed with cancer, the social worker sits in with Dr. Rouse when they do a diagnostic talk. Basically, Dr. Rouse is going to say the type of cancer it is, the medication we're going to give, the prognosis, side effects, all the medical stuff. Social workers write notes because the parent is too overwhelmed to even speak, let alone digest what's happening. So I'm taking notes and I'm writing it down, and then Dr. Rouse leaves, and then the real conversation happens. And I say, okay, so let's talk about what was said. Do you understand the child has leukemia? Do you understand the medication? And 9 times out of 10, there's something that Dr. Rouse has to come back in and explain. One of the nurse practitioners that we work with so close always said I was the closer, because I go in and make sure that they understand what's happening. And then I say, look, I need Dr. Rouse to figure out what chemo to give, the right medication, the dosage, all that, and I need her to go back in that lab and cure cancer. What I'm going to do is everything else that's not medical. So if you've got insurance questions, you've got school questions, you've got something with a sibling, I may not be able to do everything, but that's my ball of wax. That's where I come into play. So we work with explaining to the child what cancer is, and Dr. Rouse will come in and explain to the child why they have cancer, what cancer actually is, and what she's going to do about it. But she does it like only Dr. Rouse can do, and she explains it in a kid manner, so it's not as scary. It's honest. There's no hidden secrets here, but it's in a way that they can understand. And
And the thing about it is, Michelle and I are so close because we worked together for a long time, not just at work, but volunteering together. And as important as it is for the social worker or the person from the psychosocial division, child life, to sit in on the discussion where I'm talking about the treatment and the diagnosis, it's also important for the healthcare provider to sit in when that person is talking about these different things that the family is comfortable. So what we try to do is we allow each family their alone time with them, because often Michelle may be able to uncover something that they just weren't able to think about or didn't feel comfortable talking about. Or we always remind people there's nothing that's irrelevant. People will often feel like, well, this is irrelevant. We have this cruise, this plan, or we have this thing, oh, we were supposed to go see the grandparents. That's not irrelevant to us. All of that stuff is important. It's important for us to know so we can address it and sometimes say, you know, there are going to be times during your therapy, and it's not all bad and in the hospital. Like, most of our treatment is outpatient in the clinic. I tell them there are going to be some times where your blood counts are going to be really low and you are really going to be at risk for infection, and I'm going to really want you to avoid going to that big event that has lots of people there. However, birthdays don't have to be on that day. We celebrate birthdays, okay? So we're like, if we have to have your birthday party 4 weeks later, we will have it 4 weeks later, and it will be your birthday on that day. So knowing about the family stuff, and you know, cancer doesn't, like, people have to go to work. You still have to live life. You have other kids. So we really try to make a concerted effort to take care of it, because kids do not do well, nor do their parents, nor do adults, if you're only addressing the disease and not addressing all the real life other things that are happening at the same time. So, excellent question.
a lot of the things we will look at is transportation. That's a big deal. So if Dr. Rain does enroll someone on a clinical trial and it is requiring them to come to clinic 3 times a week, I'll bust my butt trying to find out what we can do to help them with the parking, the transportation, whether it's a cab or whatever. I'll work with the church. I uncover it all to find out what we can do to make it so that that family can actually get to where they need to be.
I know that I can text Michelle at any time, and I do. And I'm like, hey, I need help, because I may have 10 other patients that I have to go see, but I'm like, I really need help. This family really has some needs. This patient is doing well from a clinical standpoint, but they have a lot of social needs. And do you have anything? I'll tell you the situation. What do you have that can help them? And Michelle will uncover things that can help, because it does not matter what job you have, how much money you have, where you live. If you have to suddenly come to the Texas Medical Center in that park,
it changes so much.
in traffic 3 times a week for 6 months to 3 years, that is going to disrupt your happiness on your situation if we are not looking at that whole picture. So that even if you are clinically doing well, it will be very challenging for your mental and social situation if we don't address those needs.
Thank you so much. That is incredible, way to segue into, we have another question. Can you, hold on 1 second, sir. Can you please advance the slide, two more slides, so we go to the panel of, official panel session? Thank you. Go ahead, sir.
No, my name is Edward Sousa. I just want to commend you guys for doing this. I deal with a lot of youth in Spring School District, and this is very good information. The only time I thought about youth, personally think about youth, is from St. Jude's, one of those agencies, Texas Children, on television.
Right.
So, but I would like to see more of these kind of commitments of the community to put this out there, because when I see it, it's like, they're at St. Jude, so they're doing everything. But I don't never think about my neighbor next door or the kids I'm with or the families I'm with, okay?
Yes.
So you guys, I just want to commend you and thank you for coming, and just keep doing what you're doing to try to help our people in our community, especially our community, okay?
Exactly.
Thank you very much.
Absolutely. Thank you so
Thank you
much
so
for
much.
that. Thank
Can I
you.
just-
Yeah, please. Go ahead. Is your mic on? Thank you so much. It means a lot
think
to
it's
us from Texas Southern University, all our collaborators. We are really appreciative of that comment, and that reassures us to keep doing what we are doing. Thank you.
And part of, Texas Children's is the biggest children's hospital in the country, and we actually take care of more kids with cancer than anyone in the country. St. Jude's is a wonderful institution and mostly takes care of patients who are going on research studies that may not be available, but a child in Houston, a child who lives down the street from Fallbrook, they need to be taken care of here because your family is here. People do better where they are. And so the good thing about childhood cancer and adult cancer too, but with childhood cancer, even though we take care of more patients than anyone, we're not relying on our expertise. We all share research. We all share resources so that even if a child lives in Louisiana in a more rural area and they have to come to see me for some parts of their care, I'm trying to get them back home so they can receive some of their care there. So it's really important. And I also want to share some of the youth programs that I have for kids that are science and STEM outreach that are absolutely free. They're virtual and amazing. So I'll have to get his contact information. I can give him, I'll give you my email because I have a bunch of youth programs we do through Baylor College of Medicine that are free and teach kids about all kinds of stuff. And we have junior cancer ambassadors too.
So if I could wrap up the Q&A
Yes,
session.
please, Sandy. Question too.
I just want to say again, and I echo Edward Stussy, thank you for agreeing and asking to come here to Fallbrook for us to be a host site. It is really extremely important to get the information out in reference to cancer, period, okay, but childhood cancer as well. And my husband and I can attest to, it was a comment made earlier about childhood cancer and taking them to the doctor, et cetera. Our daughter was diagnosed with cancer when she was a freshman in college. And so when you're not familiar with any information, I know what I went through as a mom. I went straight to the computer. She went straight to the
Google.
computer.
And might I interject that we don't want you to do that?
I know.
So I've done the detective work and worked with Dr. Rouse.
Yeah, and even, I mean, it's natural that intelligent folks especially, okay, like I know your daughter is very intelligent. Intelligent folks will type in that list of symptoms, right? But if that is what gets you the medical attention, so be it. After that, rely on us and we give you verified websites and information. Because, I could go create a web page tomorrow about how to fix your car. And I can promise you, I have no knowledge on that. And it will be on the internet, right? So it's always important to have the verifiable information. I think we had one question, and then I'm going to show a couple of things that I have in Michelle too.
To wrap my comment up, there is the emotional component too. So she and I both Googled separately, and then we came together and we cried together. And then I said, basically, okay, we're gonna get our cry on, and then we're gonna figure this out.
Absolutely.
So, but the key component with us was our faith. So I don't know how faith falls into the whole spectrum of how you treat children and their families.
Everything that I do is I am allowed to do and able to do because of my faith and because of God, period. And so I tell people when I'm taking care of patients and they have strong faith, I ask them to pray for me. I tell them that science, medicine, and faith do not exist in different hemispheres. You can still have all of that, and it's really important. And I think another thing is, one thing that's really, really important, some people are very traumatized by cancer, understandably. Whether they've had someone in their family or had a personal experience, 99% of the time for a child, adolescent, young adult, that experience is not going to be the same. So sometimes people will be scared to bring their child or loved one to medical attention because they've had a traumatic experience. So one of the first things I say when I'm talking to, and Michelle knows this, when we're talking to a newly diagnosed family, I say, everything that you know about cancer in adults, I want you to take that and we're just gonna throw it out of our heads. because it is not relevant for this discussion. And I start by saying, and of course it depends on the type of cancer, I start by saying the very, very, very most likely outcome here is that we will treat you, cure you forever, and you will go on to live a long and healthy, happy life. We got to do a whole bunch of stuff to get there. It's going to kind of suck. You're not going to be able to go to school for some periods of time, and it's going to be annoying, and we're going to be doing a lot of stuff to you that you should not have to go through, and you're going to have to take a lot of medicines that you should not have to take. But we're going to get there, and we're going to do it together, and we're going to be like family, because we're going to be seeing each other a whole lot.
Right.
So, it's just really important for people's trauma to not stop them from going to medical attention, especially if it's a child or adolescent.
Yeah, thank you. Could you please advance one more slide? Thank you, sir. Please go ahead.
Dr. Ross, and thank you. I'm a cancer survivor.
Wonderful.
Thank you.
Congratulations.
And I joined Fallbrook because I saw a lady one Sunday speaking on the ministry. And she says, "Well, I want to work." When you hear the word cancer, it's frightening.
Yes.
But one of the things that I can say that helped me, I owned it.
Absolutely.
And I promised God that I would work to get men to understand that having a rectal examination is not a big deal.
So important.
It doesn't change your sexuality.
Absolutely.
You're trying to live a long life.
Absolutely.
And if you are diagnosed early enough, you will survive. I'm 6 years out.
Wonderful.
Congratulations.
Congratulations. Hallelujah.
My doctor let me go this past year. I used to go in every 6 months.
Yay.
Can you just stay away for a year?
Right.
I'm sure that felt good, right?
I did, and my PSA was 0.08.
That's amazing.
And I thank God for that.
Absolutely.
I have a young son, probably he was diagnosed with aplastic anemia. I didn't know what it was, but you talk about the caregiver side.
Yeah.
I took him every day for a long time to get blood transfusions.
Yes.
Because his red count or whatever was so low.
Yep.
But he's back.
Wonderful.
Survivorship. That's a goal.
That is, and we talk a lot about cancer, but we take care of kids with blood disorders like aplastic anemia. And that's why I say with any illness that is serious or chronic, I think all of you recognize that you will be in a position at some point, whether it's today, tomorrow, next week, where you will have to help somebody through their journey. And having the knowledge and knowing the facts and knowing that it's okay, it is horrible. I tell people this is not fair. This is terrible. This is a horrible thing to happen, and it's frightening and it's scary, but I promise you, I'm gonna walk you through this. And I promise you, we're gonna do everything in our power to not only get you through this and your whole family through this, but for you to come out better. I have actually never met a child who wasn't, I don't know what kind of amazing person they were gonna be before, but they always turn out to be the most amazing people. And I wonder, I have to think that some role of what they have to go through, that maturity level, that empathy, all of those different things, and the compassion to be able to give back to others. So I applaud you and all of our other cancer survivors and caregivers and entire families, children, siblings, because it literally affects every single person, teachers, youth workers, classmates, and the difference that you make can literally be life-changing. So all of you are cancer ambassadors, and y'all are cancer research ambassadors because you probably know a bit more than the average person and can probably help someone through it.
Yeah, that is so true. Thank you for sharing your story. For us at Texas Southern University, we have a program for prostate cancer, so I will be in touch with you afterwards to see how we can work together. Yes, that is amazing. Do we have any questions online? None? Okay. I am looking at the time, and I actually realized that I did not officially introduce Michelle. Since we just kind of, segue straight into the panel discussion. But Michelle here, she's an amazing social worker with Texas Children's. And, she has already reflected on some of the works that she does. But I really want to say thank you for making time to join us. And she has a huge setup over there with resources and goodies. So please, when this is over, feel free to stop over,
Take them for your kids, take them
for your
nieces and
neighbors.
nephews, neighbors, whoever.
One thing that we have created is a guidebook. And so if you type in right now, let's just say assistance, financial assistance for childhood cancer, there would be things that come up. But that doesn't mean they would be applicable to a person in Texas or a person of a certain diagnosis. So I've done the detective work. So I could explain more about it, but if you want to come see all the resources, we did bring a bunch of good stuff to showcase what we have available to help the families and caregivers and siblings.
And importantly, the best thing about this is that, unfortunately, we have patients and families that come to us that are in a very tough social situation, a very tough financial situation. And so not only do we have resources that are applicable for kids and families dealing with cancer, but Michelle has resources. She'll know where the food banks are, how do you get signed up, redo your Medicaid, where you can get school supplies, where you can do, because it literally is everything. So a lot of these things, even if they may not seem applicable, I promise you there'll be things in there that you'll think about someone and you'll say, you know what? And all of you can always reach out to us. And it doesn't matter what disease it is, we want you to get the very best care. So whether it's an adult, whether it's a child, whether it has anything to do with cancer or blood disorders at all, you can reach out and we can assist you. So Veronica and I work very closely together, and I lead our community outreach and engagement for our Comprehensive Cancer Center, but also for Baylor College of Medicine that looks at all other types of illnesses. And so if you need speakers for things, if you want to do more things like this, if you're interested in being on advisory boards, if you need resources, if you just need help, like we need to find a doctor, you can always reach out and I can help assist with that.
That is awesome. Can you please help me appreciate these amazing panelists? Thank you so much, Rain. Thank you, Michelle, for joining us. In the interest of time, we would, go over to the final closeout announcement, but they will be, at the table so that if anyone has any other questions, or again, we are here to support. I am a pharmacist. She's a social worker. She's a physician. You've got your entire crew right here in front of you. So please feel free to network with us, once we kind of close out, because I know we have attendees on Zoom as well, and we want to be very respectful of everyone's time. Dr. Rouse, are you going to say something?
I just wanted to thank Veronica Ajawole. I wanted to thank Dr. Liang and the entire TSU, CBMHR, and CEC for bringing these amazing, wonderful webinars and abilities to be able to talk. This is how we like to talk, like we're in a living room and be able to really, talk about things that are really important for the community. So I'm honored to be a part of it. There's nothing more important that we could be doing today. And I want to thank Fallbrook, Charlize, and her bag holder, and everyone at Fallbrook and the Cancer Ministry, all our survivors here, all our supporters here, the wonderful kids here who have been so well behaved. And all of the technical support, because it's really important and really helpful, and we value you and appreciate your commitment. So thank you so much for having us.
Thank you again, everyone. Can we go to the next slide, please? You have a question online? Go ahead. Okay, next slide, please. I'll just go through. Okay, so again, thank you for joining us. I'm just going to go through the last couple of announcements. Again, for anyone that is a community health worker, either you are here in person or you are joining us online, please make sure that you complete the sign-in sheet so that we can issue your credits to you. If you are here in person, we have our table at the lobby. Please complete our survey, okay? Your feedback is very important to us. us doing this childhood cancer discussion today is as a result of previous feedback that we received from the community. So if you want us to talk about any other disease state, any other topic of interest, please let us know that via the survey. And we are also giving away $15 gift card. Only 3 things are needed for that. Be an on-site attendee, complete the survey, and follow us on social media handles. All the information is also available at the table at the front, so that way you can pick up the information that is needed. Next slide, please. I'm really excited, to share that next month, believe it or not, it's around the corner. We will be discussing on maternal child health. This is going to be on a Friday on TSU campus, January 26th. So please do save the date. And we have been very, very blessed to have First Lady Janice Pender, the First Lady of Fallbrook Church. She will be leading us in opening prayer for that event. So please, Fallbrook Church family, we hope to see you there in person and online. And for everyone that is listening to us, feel free to be a part of that event. We'll be having no-cost mammogram for women. We'll be having a lot of screening services, a lot of information targeted towards maternal and child health. And we hope to be able to see you there at TSU campus, January 26th from 11 to 3 p.m. Next slide, please. And again, this is us, Community Engagement Corps, funded by NIH, and we have events every month. So if you look on the calendar, next one is January. The next one we're having February. We're going to talk about lupus. In March, we're talking about Alzheimer's disease. In April, really excited again to talk about clinical research and engagement. And then in May, we are talking about mental health, self-care, and making sure that we are taking care of not just, medical-related information, but also taking care of ourselves from a mental health standpoint. The calendar of events is also on the table at the foyer, so please feel free to pick up that information if you are interested, in knowing more about all the works that we do. Next slide, please. And that will be it for us today, wrapping up. And I do want to sincerely appreciate everybody that has joined us online and on site. Please receive my apologies that we started late, but I'm sure you all agree with me that this was a fantastic session, right? Thank you. Thank you for your patience with us. And I want to thank our amazing speaker and panelists. Thank you, Dr. Rouse. Thank you, Michelle. And thank you to Constellation X, for helping us with all the tech, situation. And to the tech team of Fallbrook Church. Thank you so much for supporting us. Thank you, Charlize, the Cancer Ministry, the membership of the church, and to the leadership of this church. We asked once, and you guys made it happen for us, going through all the logistics. We are very grateful. And please help me to appreciate my children, okay? I'm a mom of 4. I brought 3 of my kids, Daniel, Joshua, Deborah. Thank you for supporting me, and Jeremiah at home with my husband. I love you guys so much. And thank you to the community. We will be in touch again. Merry Christmas, Happy New Year, and be safe.